So I'm going to be taking us through the introduction to implementation science research. And I wanted to show a picture of our inaugural meeting of the Uganda Implementation Science Alliance that we've been able to set up through support from Fogati through HISA, which is the Adolescent HIV Prevention and Care Implementation Science Alliance. So this will be the roadmap for my presentation. I will take us through what implementation science is, why we need implementation science, who does implementation science, how different it is from conventional research, and my colleague will do the last bullet, taking us through examples of past implementation science projects. So I'll start with some definitions on implementation science research. So implementation science is, according to Eccles and Mittman, the study of methods or strategies to promote the systematic uptake of proven interventions, sometimes called evidence-based practices or evidence-based interventions into routine clinical practice. So on one hand, you have the evidence-based intervention or practice, and on the other hand, you have routine clinical practice. So you want to ensure that you're taking this idea or this innovation into implementation to benefit the people that you serve. So in this context, it includes the study of influences on behavior of patients, providers, and organizations in either healthcare or population settings. Another definition of implementation science is the study of processes used in the implementation of initiatives and contextual factors that affect these initiatives. And the basic intent here is to understand not only what is and what is not working, but very importantly for implementation science, how and why the implementation is going right or wrong, and thereafter testing approaches to improve it. So this is a definition from WHO. The other definition is a research that helps us to significantly improve access to efficacious interventions by developing practical solutions to common implementation problems, or the study of methods to promote integration of research findings and evidence into healthcare policy and practice. So it is integration of this evidence-based practice or EBI into either practice or a policy. And implementation science seeks to understand the behavior of healthcare professionals and other stakeholders as a key variable in sustainable uptake, adoption, and implementation of evidence-based interventions. And later on, my colleague Maggie will be taking us through some definitions of uptake, adoption, as some of the implementation outcomes that we look at. So when we talk about implementation science, it's also important for us to understand the common themes across the definitions. For example, evidence. So there is evidence that needs to be translated. That is always the starting point. For you to say you're doing implementation science research, there must be an evidence, and we've understood what an evidence is. It's validated, it's proven. So you want to translate it into a real world setting. So there's also always need for active facilitation to improve the speed. So the research here could be start by integrating the evidence practice, the evidence-based intervention into practice. But implementation science can also look at how can we improve the speed at which we are implementing this evidence, or how can we improve the quantity and quality of uptake of the evidence into routine practice settings. So as you can see over and over from the few slides that we've gone through, behavior change is inherent in the translation of evidence into practice and policy. And very importantly as well, the engagement with stakeholders is essential at all stages to improve acceptability. And Maggie will be talking about this acceptability of the intervention. You could have a very good evidence-based intervention, but there's low uptake because the intervention has not been accepted. And also generalizability is also very important for us to think about when we talk implementation science research. I like this non-scientific definition of implementation science. And according to the University of Washington, a paper published by them, it says that the intervention, because usually we tend to confuse an intervention and a strategy. So the intervention or practice or innovation or the evidence-based practice or intervention in this case is the thing. So this is the thing that you seek to implement to improve practice and thereafter the outcomes of clients if you do implementation very well. While effectiveness research looks at whether the thing works. So when you're doing effectiveness research, which I think is what we are doing a lot within the Penta network, you want to see you have this drug that has been taken through the different stages, and you want to find out, is it effective? So in implementation science, on the other hand, looks at how best to help people and places do the thing. So it is more of the how to. So you have the what, and then you want to bring in the how to ensure that the what or the thing gets implemented to become part of a policy or a practice. And implementation strategies are the stuff that we do to try to help places and people and places do the things. So you can see that the intervention is the thing. The strategy is what we are going to do to implement the thing. So main implementation outcomes here are how much and how well we do the thing. So further to explain the evidence-based intervention versus strategies, evidence-based interventions can also be seen as the what that is being implemented, the what or the thing, and implementation strategies are the how we seek to get evidence-based interventions into normal practice or clinical or community settings. For example, the thing, I'll give an example. At some point, we knew that children were failing on nevirapine and efavirenz. We introduced lopinavir, ritonavir, but the drug, much as it is effective, we know that there were challenges around the administration and the taking of lopinavir, ritonavir. The syrup was bitter. The pellets, initially the guidance was give them starting at as early as 3 months, and the children were failing to swallow. And the tablet is very big. The adolescents commonly call it PK chewing gum. So much as the drug was effective, it was not being taken. The uptake was poor. So in this case, the what or the thing that now came on board to address those challenges in order to improve viral load suppression was dolutegravir. So dolutegravir in this case is our what or the thing. That is the evidence-based intervention that we want to implement. So in Uganda, initially we saw that even though we had a very good training curriculum, we were preaching the gospel of how dolutegravir improves viral load suppression. Initially, healthcare workers were not giving the drug. Why? Because of the red flag that had come up around dolutegravir. People were scared, the health workers were scared about weight gain and all the red flags that initially we had about the drug. So much as we had the what or the thing, the implementation was not happening. So in that case, we now need the how or the strategy. And in this case, our strategy was an education strategy to ensure that we are allaying the anxiety and the fears of healthcare providers to be able to provide the drug. And as we taught over and over, repeating the same things, ensuring that the logistics are available, healthcare providers started giving children dolutegravir. So that is an example of the what and the how. So the what was dolutegravir, the how or the strategy was an educational kind of strategy to allay the anxiety and the fears of the healthcare providers. So why do we need implementation science? And this is a cartoon of scientists like us in a boardroom, and they are discussing. And here we see that it matters what we do with all the evidence that we have. So these scientists are in the boardroom, and one of them said, the latest research shows that we really should do something with all the research that we have. So sometimes we generate a lot of effectiveness information, which is really good. But if we don't get that into practice, we've not done a lot of work or a lot of what we need to do to improve the well-being of our patients. So how do we need implementation science still? So we have, for you to do implementation science, you should be able to know what the problem is. And many times our interventions are not aligned with the real barriers to behaviors involved or to the needs and priorities of our patients and communities. So in implementation science, as you saw, one of the key things is stakeholder engagement. You go beyond what your data is showing you to try and interrogate further to understand what the real barriers are before you intervene. And sometimes providers lack tools to implement relevant and effective interventions. There's also variation in effectiveness in different settings, and sometimes this is not well understood, and it impacts the results that we get from our implementation. So research cannot change outcomes unless health services and healthcare professionals adopt the findings into practice. So this is a paper that was published, and the title was How Long Does Biomedical Research Take? Studying the time taken between biomedical and health research and its translation into products, policy, and practice. So this is usually what we do. You start with preclinical animal studies, and then you go into proof of concept, the phase 1 clinical trials. We go into phase 2 and phase 3, and implementation science comes in at stage 4, where we are now getting into delivery of recommended and timely interventions to the right patients. We are translating the evidence that we've got through the phase 2 and phase 3 clinical trials into practice, and later on, this goes to population level. You're taking your intervention, you're scaling it up into the community. And this is a study by Green and colleagues, and it shows us how long it takes to move from originally research into implementation. And it's estimated that it takes 17 years to turn 14% of original research to the benefit of patients. So that is really, in one of our definitions, we say that implementation science can focus on uptake of an evidence-based intervention into practice, but it could also look at the speed at which we are taking up the evidence-based intervention. And this is one of my favorite slides that puts what we are talking about in pictorial form. So you have the evidence, but for one reason or another, the evidence is not being translated into practice. There's a gap in between, and that's where implementation science research comes in. So that gap is usually at different levels. It could be at the level of the stakeholders, and maybe a policy is lacking. It could be around delivery systems at the points of service provision. or it could also be at an individual level. So you have the evidence, but it's not translated into practice to improve the health outcomes of the clients. So what then do we need to do? We need to use the available evidence to improve public health, and this will require us to make a deliberate effort or decision to ensure that we are understanding the real barriers and coming up with interventions to address those barriers so that we bridge the no-do gap or the evidence practice gap. So who does implementation science? As you can see in the side, on the slide, implementation science is right into the center. It's a multidisciplinary science. You need everyone, and everyone can do implementation science research. That's why stakeholder engagement is very important. So every time we talk about implementation science, we also use theories, models, and frameworks to build on the knowledge of what works, where, and why. So it's important for us to understand these definitions. So when we talk about theory, it refers to any proposal about meaningful relationships between constructs, variables, or how a mechanism or construct may change the behavior of another construct or outcome. So you're basically trying to find out relationships, meanings. And in a model, we have a simplified depiction of a more complex world with relatively precise assumptions about cause and effect. So a model is helping you to understand the cause and effects. It is giving you like steps. And later on, maybe when we have an opportunity for another session, we can look at some of the models and frameworks that we use in implementation science research. So for frameworks, it usually has a broad set of constructs that organize concepts and data descriptively without specifying causal relationships. And frameworks may also provide a prescriptive series of steps summarizing how implementation should ideally be planned or carried out. And when Maggie makes her presentation, she will be able to show you practical ways of how this can be done. So this is a schema that shows us some of how the broad classifications of theories, models, and frameworks. So up here, we have theoretical approaches used in implementation science. And here we seek to understand or explain what influences implementation outcomes. And we can have determinant frameworks. So you're trying to determine what are the determinants of the problem that you have. We also have classic theories, implementation theories. We also have evaluation frameworks like the re-aim framework. An example of the determinant framework is the consolidated framework of implementation science research, which we commonly call the CIFA model. And we also have frameworks that can help you look at a process. So we have process models. We have frameworks that will help you look at barriers and facilitators, frameworks that will help you to study the implementation of an evidence-based interventions, and also frameworks that help you to evaluate what you are doing. So as I begin to wind up, I would now like to compare implementation science to conventional research. So when we're doing conventional research, we start with a hypothesis, we formulate research questions, we develop our methodology, which could be observational or experimental. We have measurements, and then our inferences are made. On the other hand, when we are doing implementation science research, we start with pre-implementation steps. So one of the things that we do, remember we said that every time you talk about implementation science, you start with, there should be an evidence that you're seeking to translate into practice. So you start by evaluating the quality of evidence, and you determine the evidence practice gap by looking at one, the performance gap or the outcome gap. and you engage stakeholders to try and understand, to get preliminary understanding about the gap. In our second step, you now get into intervention design steps, where you describe the evidence practice gap in behavior terms, and then identify barriers and enablers, and using a theoretical framework. You remember the determinants framework that we talked about on the previous slide, and then you select behaviors to change with your implementation strategy. The example I gave of dolutegravir, in that case, we needed to change the behavior by allaying anxiety that the health workers had to dolutegravir, and we used an implementation strategy of educating the health workers on what the right information is and what they need to do. So you select your evidence-based strategy for the change behavior. And then you move into implementation strategy evaluations, where you select the appropriate and feasible study design. You identify and measure the mediators of change. You select processes of how you're going to do your implementation, your health outcomes, and then you make inferences that could be descriptive or analytical. So to try and explain what we've just gone through, if you're doing an intervention study, you could have a question that says, do beta blockers prevent death after myocardial infarction? On the other hand, if you're doing implementation science research, your question could be, can performance audit reports promote and sustain beta blocker prescriptions after MI? So you can see that in the implementation science, you're doing an audit on a performance audit, and you're trying to understand, you're trying to address the how to. Yes, so because if you do the audit report, you're going to find what is not done, and then you're going to improve how it is done. The other example could be in an interventional study or conventional research, you would ask, do bed nets reduce incident malaria in highly endemic areas? From the implementation science angle, the question could potentially be, is selling bed nets or giving them away more effective in promoting adoption and usage? So again, you are looking at the how to, or you're trying to understand the behavior. Why are people not using mosquito nets? Are not using them because they don't see the value, because they didn't buy them? So you're trying to understand the behavior around the usage of the mosquito nets. The last example could be, does PrEP prevent acquisition of new HIV infections? But in implementation science, you can look at how can we scale up the use. You're looking at how you have the intervention, but for one reason or another, it's not being used. So you're asking, how can we scale up the use of PrEP? So I will quickly go through this. So if you're looking at efficacy, effectiveness, or implementation trials, these are some of the things that help us to understand the difference. For instance, the population setting, for efficacy trials, you could look at very research sites, well monitored. The effectiveness trials, you're within HIV clinics, while in an implementation trial, you want to scale up to all health facilities. So what do you need to do in order to scale up? And in terms of the outcome, for the first two, you could look at death, while in an implementation trial, you're looking at adoption. Are people taking up this intervention? So those are some of the things just to highlight the potential differences. I will not go through everything because of time. So this is further to highlight the differences between conventional and implementation research, the fact that implementation research is multidisciplinary, while in conventional research, you might minimally involve stakeholders. Here, involvement of stakeholders is key, and you're involving various stakeholders. In conventional research, we are very focused on internal validity. On the other side, we look at both. And in implementation science research, we commonly use mixed methods. So these are some of the differences that help us to understand the two disciplines. So how is implementation science different from quality improvement? Like we said, implementation science typically begins with an evidence that you want to put into practice, while quality improvement is more around the efforts that you're implementing at a clinic level, a health system level, to try and address a specific problem. On the other hand, implementation science identifies and addresses quality gaps at the provider, the clinic, and health facility level, and seeks to develop a generalizable knowledge. So this is just to show how this might also differ from operation research, where we use models, and this can be either quantitative or qualitative. And here the main aim is to aid decision-making in a complex implementation problem. So this diagram, as I come towards the end, is really to show us where the different disciplines are. At operational level, you're mainly looking at a caregiver. At a clinic level, at implementation level, you're looking at program managers who are implementing a program. And at health system level, we are looking at systems and policy makers. So I'll skip this because of time and just read this for us, that the assumption that comprehensive, elegant, real-time data sets will, in and of themselves, lead to practice change is at best an optimistic aspiration, and at worst a massive, expensive error. So meaning that we need to go beyond looking at data in our data sets to try and understand the real barriers and address them appropriately. So in summary, implementation studies focus on rates and quality of use of an evidence-based practice, the thing or the what, rather than their effects. It addresses the evidence practice gap. It uses theory-based approaches to develop and evaluate strategies to promote translation of effective health innovations into routine practice and policy. It's multidisciplinary and requires engagement with stakeholders. Thank you very much, and over to you.
I'll give examples of a few implementation science studies. In terms of outline, I'll give an example of diagnostic studies, then vaccine implementation studies. And if we get an opportunity, innovative digital approaches, implementation science studies, and conclude. So I'll start with this slide. Eleanor, thank you so much for the wonderful introduction. Because of time, as Eleanor said, we'll do introductions of different designs later on, but today I'll focus on a few designs, especially the hybrid designs, and I'll give 3 examples. One, the first study will be a hybrid type 1 study, where we will show how you can use intervention effectiveness outcomes as you test for clinical intervention outcomes. So it could be sensitivity of a test or specificity of a test, but also gather data on implementation, like Eleanor said, acceptability, adoption, and others. Then I'll show another type of study, hybrid type 2, where you are focusing on both the health services outcomes and also testing implementation strategy. So you want to test for both the sensitivity of the test and specificity of the test, but also a strategy like she was giving of, let's say, education of how to use that test and how that worked and whether the uptake was good, the adoption was good, and acceptability was good. And lastly, you have hybrid type 3, where you focus on the implementation strategy. So in the case that Eleanor gave, the education of staff on dolutegravir, and then observe or gather data on clinical prevention outcomes. So as next, it is very important to understand the difference between an evidence-based intervention and a strategy. Next. for my talk, I'll focus on 2 implementation strategies, the education, like Eleanor said, but I'll also give you another example of a restructure, which is one of the strategies in box 9. You can either change the delivery of an intervention. For instance, instead of giving the intervention in the health facility, you can decide to go to the community where patients are and give the intervention right there. So that's restructuring on the delivery of an intervention. Next slide. Acceptability is really the perception among stakeholders on how agreeable an intervention is. Adoption, she mentioned already, the intention to use an intervention could be a test or a drug. Appropriateness, on the other hand, is the relevance of the intervention on the perceived fit. And I'll use all this for my studies. Feasibility, the extent to which an intervention can be carried out in a particular setting. Next one. Fidelity is the degree to which an intervention or a protocol was implemented as originally designed. Implementation cost is the incremental cost of the implementation strategy, and penetration or coverage is the extent to which an intervention or test is integrated within a service. And lastly, sustainability, the extent to which an intervention is maintained or institutionalized. Next slide. So, next slide. I'll use the determinant and process models, next slide, in my talk. Next slide, sorry. This is just to show you what Eleanor had said. The what of the first study that I'm going to talk about is the fact that there is a long turnaround time of test results when qPCR using dried blood spot protocol is used for infant diagnosis of HIV. So the evidence-based intervention that I focused on in my studies was CEPHED Expert HIV whole blood protocol, which we know you can use. A patient can wait for test results, same day get results, and hopefully improve initiation of ART. But the strategy, implementation strategy that I wanted to assess was the educate, training of health workers to use this test, but also caregivers and parents of the patients. The implementation outcomes that I wanted to focus on were uptake of this CEPHED whole blood protocol, because it had not been implemented in Malawi before, feasibility, acceptability, which I've already defined, appropriateness, and cost effectiveness. The effectiveness of health outcomes were sensitivity and specificity of the test, because it had been qualified by WHO, but not used on a larger scale in Malawi. We also wanted to gather data on turnaround time of test results and ART initiation, and some of the patient outcomes were satisfaction and proportion of patients initiating ART. Next slide. So globally, we all know that ART coverage for pregnant women is really good, 81%. But when these women give birth, HIV-exposed infants globally have shown, results have shown that only 62% of infants have had EID by 8 weeks. It's high in other parts of the world, 71% for East and Southern Africa. But when these children diagnose and initiate ART, the coverage is as good as it is for adults. It's 52% for these children aged 0 to 14, but 76% for adults. So you can see why we were motivated to assess whether this evidence-based intervention, the whole blood protocol, using the delivery strategy educate, next slide, would help and improve coverage of EID as the ambitious UNAIDS target, which states 95% of people, even with HIV, should know their status, and of those 95% should be on treatment, and of those 95% should have undetectable viral load. So for Malawi, here you'd have to click fast to show, because I thought I'd be doing it myself. For Malawi, EID coverage is 79%. For pregnant women, treatment, 93% are on treatment, but if you compare with children, it's only, next, oh, sorry. Sorry. Next. Treatment, only 74% are on treatment, and for viral load, for adults it's 94%, but if you see for children aged 10 to 19, next, it's 81%, much lower than adults, and even worse for children aged 0 to 9. Next. So we really wanted to overcome this issue of using dried blood spot, getting them to dry, take them to another facility and have an overload, as you can see, a backlog before the dried blood spot got tested using the qPCR Abbott. Next. We wanted to use this whole blood spot, which is a whole blood protocol, which, as I mentioned, you could just test, put it into the cartridge, get results same day. Next. And we had then used the strategy, educate to train laboratory technicians and nurses on how to do whole blood testing. Next. And the results showed that if we compared Cepheid Expert whole blood protocol to PCR as the gold standard, sensitivity, our primary aims were sensitivity, specificity, turnaround time, as I mentioned. Those were the effectiveness outcomes. The secondary outcomes were tech feasibility, acceptability, appropriateness, and cost effectiveness. Next slide. We recruited 713 children in 2 health facilities in Malawi. Out of these, 124 were children and 11% are HIV positive. Next. Sensitivity was 96%. Next. Specificity was 98.1%. I think, Mateo, you just keep clicking, so I just speak faster according to your pace. Turnaround time of results was 5 hours. And next, you just keep clicking. I'll be speaking around you because it will take long otherwise. Next slide. Expert HIV whole blood testing was found to be acceptable to caregivers and health workers. Majority of the parents had no concerns about the blood testing process, and only a few thought it was painful for the child. Next. In terms of cost effectiveness, its cost of $42 was cheaper than PCR, which was $67. And if Malawi government had used this, they would have spent 1.9 million and saved 1.1 million. And overall, laboratory technicians found it acceptable, appropriate, feasible, and user-friendly. Next slide. So you see, that's the time I stumbled upon implementation science. That's when my interest came. I could have used this model, but at that time I didn't know about models. As you can see, I already gathered data on complexity of the intervention, its readiness, and also patient characteristics and so many other parameters. Next slide. I could have also used CIFA, which Eleanor mentioned, because it looks at intervention characteristics, which I've studied sensitivity, specificity, and looked at the evidence and the that was already out there. I also looked at all these other parameters, the patient characteristics in the outer setting, the inner setting, the health facility, readiness for implementation, communication, and a few other things. So these were all models I could, or frameworks I could have used. Next slide. So this is a summary slide, which is showing you the gap, the evidence-based intervention that I used. The model, as we mentioned, could have been CIFA and PRISM, and the stakeholders, Ministry of Health, the CUHES, as well as all the other parameters that you need in an implementation science study. So you also see what Eleanor had said. We use multidisciplinary team approach to assess all these implementation processes, mixed methods, and the analysis. I use everything you do for a diagnostic test accuracy study and sensitivity and specificity, but I also use thematic analysis for acceptability and cost effectiveness, as well as doing all the sensitivity analysis as you do for any cost effectiveness study. And we then gave feedback to the stakeholders who said, this is all great. Yes, all this is good, but for sustainability, acquisition of EDTA bottles is a challenge, so we need to think about it. So we'll move on to the next study, but I'll quickly say that there was a PhD student who carried on this work and did the CIFA. Next slide. framework to gather data on barriers to EID and ART initiation. Next slide. I've already gone through the CIFA, but this was just to show you when you analyze the data, you have results which look like this. The innovation or recipients, the caregivers, what are their issues? So it could be lack of understanding of the processes, fear and all that. The deliverers, what are their issues? It was like insufficient knowledge and all that. So that's one domain, characteristics of individuals. You go to the next domain, next slide. It's inner setting, the health facility. What were the issues there? Lack of resources, human resource, therefore low levels of human resource, delay in treatment, delay in delivering results. The caregivers who went to these facilities thought there was lack of privacy, poor treatment by health workers. So they didn't want to go to these facilities anymore, and so on. Next slide. So I now want to give an example of a hybrid type 2. During the pandemic, we were approached by my collaborators at KUHES. They asked if they could use some of our loop-mediated isothermal amplification master mix that we're using for HIV work. And I said, why not? And we came up with this study where we assess validation, acceptability, feasibility, and testing of SARS-CoV-2 loop-mediated isothermal amplification assay. From now on, I'll just call it SARS-LAM. But it was a pandemic new test. We had to optimize the use in real-life setting, but also see if it's a test that we could implement. So yes, there was a need to find a test that was a nucleic acid test that was cheaper. Research had shown us that SARS-CoV-2 LAMP had a sensitivity of 73 to 100%. And then I aimed to come up with an assay that would mirror that and detect at least CT values of less than 30, sensitivity of 95, and also assess implementation outcomes, assess acceptability, feasibility, user-friendliness, and all that. So the evidence-based approach this time was SARS-LAM, but because I wanted to use it in a low-middle income country, we wanted to make sure that it should be RNA extraction free. Just collect your swab, mix it with master mix and primers, put in this machine, get your result. The strategy, again, we had to educate and train people, different clientele this time. In a pandemic, we have clients who are COVID suspects and contacts, laboratory technicians, nurses. Next slide. And unlike the first study, I was testing these poems, the effectiveness as well as the implementation outcomes. Next slide. This was the site, a COVID tent, and therefore I was also assessing all the barriers to testing, all the enablers, facilitators, the testing experience, and everything that the patients went through. Next slide. By this time, I had now known that there are models, so I used the technology acceptance model. Matteo, click on the link. It will say to you, then the second hand, it will ask you to skip, and then the form will come.
Sorry, it doesn't work.
You can just continue to next slide. The reason I wanted to show it is because the technology acceptance model has different domains. The perceived fitness, the relevance. It also asks the healthcare workers to reflect. Can they use this? Can they recommend it to their colleagues? Would they be happy to use it? And there are 6 domains, and there's so many questions in all of them. Next slide. So after gathering data on all the domains, then I'll present the results. For sensitivity, in the optimization phase, it was the same as the sensitivity in the literature, 73%. Specificity was 100%. Next slide. And turnaround time results was about 4 hours. Next slide. I then moved on to do the prospective study. I recruited 450 people. Adolescents and younger children aged 13, 14 were among the under 40. Next slide. We then also tested sensitivity and specificity in real life, real world setting. As Eleanor had mentioned, you need to test in real life. After you've done your efficacy, you go to real life. And sensitivity again was 73%, like in literature. Specificity was 100% again. Next slide. Turnaround time of results was around 4 hours. Next slide. And next slide. But the reason I share this example, unlike the CEPED example, the health workers and the COVID suspects and contacts had different experience. The COVID suspects just wanted a test that would tell them you've got COVID, and then they would know how to be managed. But for the health workers, they felt that because they had to add primers to master mix and then put in the sample and test and get a result, that whole process was a little bit more complex compared to just using a simple rapid antigen test like the PanBio that was available in Malawi at that time. And later on, Express SARS-CoV-2 became available and is similar to the HIV example that I showed. So you can see that even though the test was not was as sensitive and specific as literature had shown, but the implementation outcomes at the same time as we're collecting the effectiveness outcomes showed us that that test would not be easily used by laboratory technicians if PanBio and Express SARS-CoV-2 are available. So we already knew at that time that, yes, this test, yes, it's sensitive and specific, but it will just sit on the shelves if we take it forward and we push that it should be used in laboratories, because laboratory technicians have already shown us that it is not easy to implement. They would prefer other tests. Next slide. So you see, as an implementation science study, again, I've shown the gap. PCR was not readily available, low uptake of COVID-19 testing. The protocol we used was this RNA extraction free. We used the model, the technology acceptance model. We tested readiness for adoption of this new test, and yes, they were keen, but after training them and all that, different multidisciplinary team, our mixed methods were done, but we found that feasibility, appropriateness were really not as good for this test compared to a rapid antigen test. Next slide. The last example I'll give of a hybrid type 3 is the use of this study PRISM. PRISM is preventing infant infections with implementation science in Malawi. It has 3 studies, but we'll focus on just one, which will be linked to the first study that I shared on using CEPED expert whole blood protocol, using a point of care test, which is the CEPED gene expert machine. We already know that lots of we still have a high number of high-risk mother-infant pairs in our communities, and high numbers of mothers become infected during pregnancy, and resultant new infant infections occur during breastfeeding. And there's also high ART dropouts and poor viral monitoring. So what this study now wants to do is to use the point-of-care testing and use it for early infant diagnosis as well as viral load monitoring. But the strategy is now different. Unlike hybrid type 1 that I used, educate strategy, this study wants to use the restructure strategy. So because they know the mother-infant pairs who are high risk cannot come to the health facilities, they decided that they will now take the point-of-care test to the community where the mother-infant pairs are. So you can see that the evidence-based intervention is still the point-of-care test for EID and viral load monitoring, but the strategy is different. They are restructuring. They'll first identify the mothers who are high risk using EMTCT and ART records. Then they'll go to the community where these mothers are and give them the point-of-care test. And then hopefully there'll be same-day ART initiation. Now, next slide. In this study, which is a stepped wedge trial, they plan to recruit clusters in a given period of time. So starting with initially 3 clusters and then adding on. Initially, they'll just be standard of care, and then others will get standard of care and the point of care testing and viral load monitoring. And then more and more clusters will be added to this arm. But the primary aim is to assess adoption, the number of settings that will take up this intervention, and factors that are affecting this model. Fidelity, which I explained already, and sustainability. are the two other main implementation outcomes that they're after. But they'll secondarily gather clinical outcomes like maternal HIV diagnosis and new HIV infant diagnosis. So hopefully you've been able to appreciate how you can use different designs, having type 1, 2, 3, how you can use different strategies, and how all these studies have shown effectiveness and intervention implementation outcomes.
What were your results, so Maggie, of the HIV study that you presented?
Noella, do you want to ask the question and just clarify which study? Yeah. Was that the first hybrid example that Maggie gave?
Yes, Gareth, and that's the first the study that she did with the PCR test on the infants, the EID testing one. Just wanted to know what this. It was a very good study, so I was just curious to know what the results of that were.
Could you answer that, Maggie?
Yeah, thank you. So, yeah, so we had many outcomes from that study. I think the key finding was that safe and expert whole blood protocol was as sensitive and as specific as PCR. So that's the effectiveness outcome. And secondly, the turnaround time was only 4 hours with a range of 2, because sometimes patients would just be tested immediately and then they would get results. But if we just let natural flow of things happen, sometimes they waited up to 4 or 5 hours because the laboratory technicians were doing other jobs. Again, 73% of all the infants that were HIV infected were able to initiate ART the same day. The other percentage, the caregivers wanted to go to their spouses to ask and discuss, get permission to start ART. For implementation outcomes, like I mentioned, laboratory technicians found it easy to use. The district health management team was quite ready and eager to implement expert HIV protocol. And in Malawi, there were issues of vampirism, and we were worried that people may not be happy to see that we're taking whole blood, putting it in an EDTA, going for testing. But parents and health workers were all accepting of that method of testing. So it was really acceptable, found user-friendly, and also cost-effective compared to PCR. Thank you.
Okay. Eleanor, can I come back to you? And firstly, I'm quite interested to ask you to comment on the examples that Maggie gave, and if there are specific examples that you can think of that perhaps Maggie hasn't touched on that you really want the audience to grasp to get a better understanding of implementation science.
Thank you very much. Thank you very much, Gareth. And thank you, Maggie, for really great examples taking us through the different designs. And Maggie has done a great job taking us through the different hybrid designs. Just to emphasize that when we are looking at the hybrid designs, in the hybrid one, we are looking at studies that you are doing like a clinical study, and you want your outcome here is trying to understand more around how the implementation is being done. So you have your evidence-based practice, and you're trying to understand how the implementation is going to be done. So the example of the DTG example that I mentioned would be a good fit for that. And in type 3, an example that I can quickly think about is let's say you are doing differentiated service delivery models. I'll give an example. In Uganda, we have seen that our clients are generally not going into the community models of differentiated service delivery models. So we are beginning to think maybe it's an issue of stigma. If you put a community center in my neighborhood, I might not want for everyone to know, oh, people are getting drugs under that mango tree. Most likely they are HIV positive. So in this case, you would want to study, find out barriers, facilitators, and then design an intervention to try and address the challenge or the reason why people are not getting their ARVs in the community. So if you come up with an intervention, maybe let's say the intervention could be that you are going for, instead, you're going to do door-to-door to deliver drugs, and people will no longer come under a mango tree, so people don't have to know that people are gathering under this tree for this reason. So your intervention or strategies to make sure that you are coming to people where they are. So if you want to evaluate the effectiveness of that model to see are people now suppressing on treatment, are they becoming retained in care? In that case, it would be a type 3 because you have this strategy that you're implementing. You're moving from under mango tree to do home delivery. And now you want to see clients who are in home delivery, are they still suppressing like they would come to the clinic? So in that case, that would be a type 3. You have your strategy, and now you're looking backwards to see the clinical effectiveness. And then in type 2, you'd be testing both an intervention to see its effectiveness, but you're also at the same time trying to understand whether how it's being implemented. So that's what I would want to add to what.
Okay. Yeah. Thank you. Thank you. Adelia, you've got your hand up. Please go ahead. You're on mute at the moment, Adelia.
Classical. Yeah. Thanks. Okay. Thanks, Gareth, and thanks for a great session. Eleanor, I was really struck by the slide you presented, telling us that after I don't know how many years, only 14% of the science which can be implemented is implemented. I mean, that is really what's happening there. What do you think are the main drivers for that? I know it must be multifactorial, many reasons, but what is the main problem here?
Mm-hmm. Yeah. Thank you very much for, I'll just show that slide again. Thank you very much for that question. I guess the main thing or the key message that we are taking from we take from here is that if we don't get into if we don't wear our implementation science hats, it's very possible that you could come up with a very good intervention and nobody is taking it up. So as you've said, it is usually multifactorial. It could be that, and let me start with this one, that the biggest challenge is the disconnect between the researchers and the policymakers and implementers. So if I'm working in an academic institution and my focus is how many papers am I churning out so that maybe I can move from being a senior lecturer to an associate professor, my focus is going to be on conducting studies and making sure I'm publishing. On the other hand, the program implementer is also doing their best to make sure that they are implementing policies, but where is the evidence? So I think the biggest disconnect, I would say the biggest challenge for this 17 years and the very low uptake of the content or the research findings is the disconnect between the researchers and the policymakers. And what we are beginning to do in Uganda, my second slide, which had a picture, where we were having an inaugural meeting, we are working closely with a team at Makerere University, working closely with the Ministry of Health to be able to bridge that disconnect. And we're beginning to see that now research findings are being translated into policy, because we've also taken part of the people within the academia or research institutions, academic institutions, to be the co-chairs of our technical working groups in the Ministry of Health. So that clever move has helped us to ensure that we are working together, and also that the timing of the release of results fits in with the time we are reviewing policy. Because once the two teams are not working together, you come up with your evidence, but as a program person, it takes me almost 2 years to revise my guidelines. So when you come and I've just completed that process, I'm probably not going to go back to uptake your evidence. And also the cost of disseminating a policy, a change in policy, the printing of the guidelines, the